Our second topic of the tonight in our speed round here is going to be access to healthcare. How can we lower the barriers to access to healthcare so that we can provide the same good, high quality access everywhere? This does not necessarily mean that, look, creating a single payer system or this idea of, everybody gets subsidized at the same level, because let's be honest, to get what you pay for. The point is everybody should have equal ability to access the same quality of care, regardless of race, geographic location, or socioeconomic status. So what are the major issues that we see out there right now? And can anyone think of ideas of ways to address them?
I would just add to that disparities in healthcare have really risen, I think, to the forefront as we look at COVID and what has happened. So again,
people with the exact same access to the same care, and yet the outcome in terms of mortality rates based on background.
Exactly, 100%. So go ahead and raise your hand if you're interested in speaking. Jeff, go ahead.
So I would just say, to begin with, part of it is just confusion in navigating the system. I mean, I'm a physician, but I'm also a bad patient. And I mean, it's confusing for me to try to go find a physician if, I need primary care help or whatever it is. So it's like, particularly people that maybe in challenging socioeconomic status, and they probably have a horrible time trying to navigate the system to find a physician or to figure out how they can, get a physician and not get stuck with a huge bill. So I think, navigating the system or improvements in that will help.
And I would add to that technology and innovation absolutely could help in that space. Who would like to go next? Dimple, go ahead.
Hello. So, this access issue is very interesting because there's been a big push towards virtual care, videos, telephone, you name it. So it is kind of expanded the reach of the individual providers and health systems out there. The concern I have is that sometimes it takes about 4 to 5 virtual visits to equal 1 in-person visit. And so as we look towards expanding access, I think the key to what Michael said was the quality of what is being provided. Because if you have to reach out to your provider or doctor 4 times virtually, and it could have been done in 1 in-person visit, that's not really creating efficiencies or better access in the system, right? So I think it's very nuanced, it's complicated. We want to expand, especially into rural areas where people don't necessarily have access. And I think there's a big push to do that even at the federal level, of providing critical access hospitals, better funds, and the access to telemedicine so that they can bring specialists into some communities that wouldn't typically have access to those specialists unless they drove 3 hours, 4 hours away. And I do think that's where the value will come in, is access to specialty care will definitely expand with virtual care. But I worry that primary care moving into a lot of this virtual space we may be replacing 4 or 5 virtual visits for 1 in-person visit. So we just need to be careful.
Yeah, this is Ian Sarenbach. Yeah, very interesting discussion. As I listened to all this, and I think the comment was made early on, as one thinks about access to healthcare, you immediately think, well, can you have a video visit? Is there a clinic, an office that you can visit? I think the comment that was made sort of resonated with me as a physician now who's just retired, but been a physician for 45 years. And that is that I think we haven't done a very good job of educating people about what's available. Now, may technology and help, I think so, but I think we need to find better ways for patients or potential patients to find physicians that they may need. We need to do a lot better at educating the public about preventive medicine, be it physical or mental. And if you say to me, well, how do you do that? I have no idea. But I do know that that's probably at a fundamental level where it resides. I think if you look at this whole mess related to vaccination, I think the rollout in terms of politicizing it was one thing, but I don't think the medical community did a very good job of providing confidence in what they spoke about. I mean, there are things you know and there are things you don't know. Well, if you don't know, you've got to make that clear. And so it falls into this category of how do you message correctly and ultimately how do you communicate better. And I think as physicians everywhere, the stress of your daily activities makes communication sometimes challenging. You've got a limited amount of time and you just cannot get it all verbalized one-on-one with a patient. So that's what would be my recommendation.
I agree with you. And I think the other piece of it really is around, how do we help people understand this is very appropriate for a virtual visit or a telehealth visit. And these are things that really you should be seen in person for. So helping them kind of choose the path or navigating, as Jeff mentioned earlier. Ramin, go ahead.
Before I say what I was going to say, I was just going to piggyback on what the last doctor said. I'm sorry, I don't know his name, but I agree that the rollout of the vaccine and the mask mandates, I think, was a huge stumbling block in the sense that the authorities kept changing their minds, and it makes the authorities lose their own credibility. So I think it's embarrassing for healthcare workers, for all of us to deal with.
Unfortunate for sure.
Yes, personally, I'm a primary care physician. I work for a company. Before COVID, we used to exclusively make house calls. And the great thing about house calls is we were providing primary care to people in their homes. And these were people who were unable to leave their homes to go see a doctor. And we were basically providing care to people who were not getting care. And they were treating ERs as their primary care doctors. And we helped Medicare save a lot of money because we were keeping the high utilizers out of the hospital. Matter of fact, the company I work for proved how cost effective it is. In 2019, Medicare passed a law allowing all Medicare recipients to get a visiting doctor. You no longer had to be housebound. 2020, COVID came, and everything we had worked so hard to achieve basically went to the pile. And we switched to telemedicine basically overnight. And a year and a half, 2 years into it, we're trying to ramp up and go back to making house calls, but we still have a lot of telemedicine. Telemedicine will eventually probably be 20% of the primary care we deliver. But the biggest challenge is the average patient that we see is 80 years young, and the average 80-year young patient doesn't have an iPhone or they don't know how to use it. And we'll have our staff call them and talk to them and explain to them that we literally text them a link and they got to click on the link and we can do a video visit. We initially used to use FaceTime and Duo because of the COVID pandemic, but now as things are winding down, those are not HIPAA compliant, so we're using our own telemedicine platform. But the difficulty is the patients are really, really not tech savvy people. These are people that really benefit from house calls. However, their caregivers and their children, who are usually in their 60s, are all tech savvy and they all have iPhones. So the patients that have the caregivers or the children who are actually involved in the home have a huge leg up than the ones who don't. And my company has struggled with this for over a year. I don't really, unfortunately, see a solution to this because it's just kind of a generational divide, is especially an 80-year-old who's not motivated to learn how to use a smartphone. You just can't make them, kind of like you can't force compliance on people. But the company I work for has gone through a lot of transition, and I just think, because of the pandemic, there's a lot more to come. But virtual care is definitely here to stay, but it'll be at least a small portion of what my company does.
Yes. Thank you, Ramin. reducing disparities in healthcare. How do we do it? John.
Just real quickly, I just wanted to make a note that the AMA, during the most recent meeting, they voted to recognize that your bandwidth is now a social determinant of health. And so I think that's a very timely discussion, and it's something that's being recognized by our professional societies.
I'm just curious, one of the things, like I had a friend who had cancer, that accessibility came down in, she had one MRI that she got a bill for $5,000, and she had a second MRI that she got a bill for $30,000. Of course, she didn't know about it. So, like healthcare disclosure, I'm just curious, maybe from a physician's perspective on disparities in pricing, because she went to this facility and then she went to that one 5 blocks down. Like, what do you guys have a perspective on that?
I'll just say it before we wait for someone to raise their hand, because I'd love for other people to chime in. Cost conversations, though, that have entered into the exam room, I would say is something that has come, more in the last, 5 years than any time before that. And you are seeing people make decisions based on cost, which I think may or may not be the right thing, right? There are probably benefits to that, and there are definitely people who lose out in that scenario. Bob, go ahead.
I was just going to say that the surprise billing issues that are being brought up across the country are really critically important. And I think it addresses the issues you're just raising, but it also brings together people so that you can't dictate what someone's going to charge for something, but you certainly can point out to patients that they have a choice. And when people start using their wallet as a choice, I think the rest of the health system will have to come along. It's pretty typical that the consumer can drive this when the consumer knows and has the information and education for it.
And I would just add that, some of these extraneous bills come from repeat studies that might not be necessary because, physicians have a hard time getting access to records or imaging studies that might be in different health systems or different institutions. And sometimes the patients have a CD and they can upload it. Sometimes they can't. Sometimes it's difficult. And then sometimes, people just wind up repeating the study because they can't get access to the old study that may have been done recently. So there are issues with information transfer and imaging sharing that also tie into all of this.
Great point. Dan, go ahead. And then Robin.
Yeah, definitely one of the issues is education among physicians too, like knowing the actual price of the tests that we're ordering. And then, it's such a black box on what a patient will actually get as their final bill. There's so many different components to billing. And I think anyone trying to even shop around for different tests, it's hard to get a straight answer because there's so many different components. So it really needs to be an effort on every part of the billing system to come together and be more transparent and make it easier.
Great, thank you. And Robin?
Yeah, I agree about the price transparency, and a lot of systems are following like the CMS guidelines they have benchmark rates for pricing, and usually a lot of commercial insurances measure off of that. And then the second component is there's probably a component, particularly with diagnostic imaging, of an AI formulas where people are using AI as technology to predict pricing or find patterns in the data. And so that's kind of a new and evolving area. Like with AI, it's not just for clinical, but they're using it in business. Everybody's has an analytical formula.
What you guys are talking about actually is brilliantly addressed in our digital divide ask. We have Ed Miller from the Center for Medical Interoperability, and we have a long conversation about that. But I'd love to pull us a little bit back towards how do we encourage better access for, minorities or socioeconomic status or on Indian reservations or whatever it may be.
I want to throw out there, just because it's an area that I've spent a little time on implicit bias. So talking about, okay, like if you look at, we could talk about COVID-19. We know that the data is heavily weighted in one side or the other. Why are some folks getting better care and having less death rates, et cetera, than minorities and others? And what is playing a part in that? And then again, I would bring up implicit bias, and what role does that have from a provider standpoint? How does that play a part in it?
It's a deep
Just a
data
question.
well in that space as well, because everybody's coming in essentially as emergency care, like it's insurance agnostic.